Let's go on with the meeting, and the moderator of the third session is Dr. Massimo Zecchin. He's a cardiologist at in Trieste of our university, and
Thank you very much, Stefano. I'm very happy to be here. I'm happy also that there are so many young people attending this meeting, very interesting meeting, and we hope that we can go on with other interesting sessions with old and new friends. First of all, I should introduce my old friend Gherardo Finocchiaro, who is now in London, I guess. I hope the connection is ready. Hi, Gherardo, how are you?
Hello, I'm good. Thank you very much. Thank you for inviting me.
Okay, so he will speak about sudden death, sudden cardiac death in athletes, which is his main point of interest, and we are sure that we will have a very interesting and expert presentation. Thank you very much.
Thank you very much. I hope you can see my slides. Okay. All right. So thanks again for inviting me. It's a really great Congress. I'm a little bit sad that I cannot be there in person, but hopefully I will be able to deliver some useful messages remotely. So in the next 15 minutes or so, we're going to discuss about sudden cardiac death in athletes. And first of all, let's discuss about the epidemiology, because we all know that sudden cardiac death in athletes is a rare, although tragic event. But if we're asked how frequent or how rare it is, I think it's more difficult to answer this question. And I would like to use this table from a recent state of arts review that we published in JACC, and you see that the numbers are very different. So we have numbers ranging from 0.3 in 100,000 individuals to 6.8 in 100,000 individuals per year. So there is an extreme variability according to the cohorts studied. Another important question is whether there are high-risk populations, and certainly this study from our colleagues from the United States, led by the Seattle group, showed that there are certainly some high-risk populations. In this study, which was based on a national registry on NCAA college athletes, so very young athletes, aged 19 to 23, the incidence of sudden cardiac death was particularly high in male basketball players. It was 1 in 5,200 athletes per year. On the other side of the spectrum, this is another American study, not based on a national registry, but it was based on a registry in the state of Minnesota. The age of athletes was slightly younger, so age 15 to 18. And you see that during a span of 20 years, the authors identified only 4 sudden cardiac deaths, which equates to an approximate incidence of 0.3 per 100,000 athletes per year. As I said, on the other side of the spectrum, this is a UK study, a national effort on FA athletes, Football Association, young athletes who were all screened with ECG and echocardiogram age 16, more than 11,000 footballers who were followed. Mean follow-up was 7 years. You see that the most common cause of death was cardiac, and sudden death accounted for 6.8 per 100,000 athletes per year event. We have to remember that sudden cardiac death, does not occur only in high professional athletes, but it can occur also in recreational athletes, or even in young non-athletes. I would like to discuss now about the etiology of sudden cardiac death, which is another very controversial issue. And I think that most of you know this pie chart, which derives from two important studies published, led by Dr. Marans in the United States. And these studies were based on national registry of young athletes who died suddenly. For these studies, young meant less than 39 years of age. And you see that hypertrophic cardiomyopathy was the most common cause of sudden death in these individuals. So in some way, these studies created a notion, the opinion, that hypertrophic cardiomyopathy is the most common cause of sudden death in athletes. But I will show you in the next few minutes that other studies, perhaps more recent studies, including from our group, showed a very different story. So this is a study from the Padova group based on a large cohort of sudden death events in young people and in athletes. And you see that the most common cause of sudden death in this cohort, this was based on the Veneto region, around 5 million individuals, was arrhythmogenic right ventricular cardiomyopathy. This is a study from the United States. It was not based only in athletes, but it was based on military personnel, so physically active individuals. And you see that in individuals who died suddenly, less than 35 years of age, sudden unexplained death, which basically means a normal heart at a postmortem examination, was predominant, 41% of the cases. I would like to cite the study that we mentioned before, the national study on NCAA athletes, so college athletes. And you see that the authors emphasized that sudden unexplained death, so sudden death without a structural cause, was predominant, 25% of the cases. Hypertrophic cardiomyopathy, very rare, just in 8% of cases. So these studies and others, which I will show you from our group as well, in some way told us that hypertrophic cardiomyopathy is a possible cause of sudden death. It's certainly not a predominant cause of sudden death, which can be caused by very different etiologies, from dilated cardiomyopathy to sudden unexplained death, so a normal heart at postmortem, coronary artery anomalies, idiopathic fibrosis, and LVH, which we will touch upon in the next few slides. I would like to show you briefly our experience at St. George's Hospital and University. I had the pleasure to work with Professor Mary Shepherd for the last 10 years, and the way it works in the United Kingdom, when there is a sudden death, of course, the case goes to the local pathologist and to the local coroner, and the case can be referred to a center of excellence, such as St. George's Hospital, and the heart undergoes a very appropriate and very detailed investigation that includes a macroscopic and microscopic histopathological assessment of the heart. So with this study published in 2016, we wanted to assess the causes and circumstances of sudden death in a large cohort of athletes. And you can see from this pie chart 357 athletes who died suddenly, 90% were males. And you see that in 42% of cases, sudden death was nothing was found at the postmortem examination. So something that we call sudden arrhythmic death syndrome, 42% of cases. And you see that there is a certain variability in terms of age. So very young individuals, aged less than 18, tend to die with a normal postmortem examination in most of the cases, 56% of the cases. Older individuals, other conditions such as cardiomyopathies tend to be more prevalent. So this study was published in 2016. This other study was published just a few months after our study, and this is an effort from our Australian and New Zealand colleagues. This is a study not on athletes, but simply on young individuals aged less than 35. And you see that these authors describe situations where unexplained sudden cardiac death, which basically means sudden arrhythmic death syndrome or sudden unexplained death, was predominant, 40% of cases. Another point I would like to make is that if you're an athlete and you're dying suddenly, that does not mean that you need to die during exertion. You can die at rest, during your daily activities, or even during sleep. Certainly, there are certain situations and conditions that seems to be associated with sudden death during exercise. And according to our study, left ventricular fibrosis and most importantly, arrhythmogenic cardiomyopathy seems to be associated with sudden death during exertion. There are certain variables that we need to take in consideration when we are studying sudden death in young individuals and in athletes. Certainly age, sex, and ethnicity are very important. Starting with age, and I would like to share with you this graph, which is very important. So after the age of 35, certainly out-of-hospital cardiac arrest, sudden death in athletes and non-athletes is mainly caused by coronary artery disease, by atherosclerotic coronary artery disease. But if we look at individuals who are of age less than 35, inherited cardiac conditions, including cardiomyopathies and channelopathies, sudden arrhythmia death syndrome is likely caused by a channelopathy, primary arrhythmia syndrome without structural abnormalities of the heart, and coronary artery anomalies are predominant. Certainly young may mean different things. We may have very young individuals, such as adolescents. And with this study, which was published last year in JACC, we wanted to investigate this specific aspect. So adolescents, age 10 to 18, who die suddenly, large population, more than 700 individuals. And you see that the sudden arrhythmia death syndrome, normal heart at the post-mortem, was predominant, 63% of cases. There were 128 athletes, the remaining 628 were non-athletes. Few points. Coronary artery anomalies accounted for 9% of deaths in athletes compared to 1% in non-athletes. So strong association between coronary artery anomalies and death in athletes. And commercial cordis as well tend to be more common in athletes. Individuals who died at rest were more likely to demonstrate a normal heart at the postmortem examination. And there were certain conditions where the risk to die during exertion, during exercise, appeared to be higher, such as, for example, arrhythmogenic cardiomyopathy, an underlying hypertrophic cardiomyopathy, left ventricular fibrosis, and again, coronary artery anomalies. If we look at the death during rest versus death during exercise, we see that very young individuals, so age 10, 11, 12, 13, seem to die suddenly during exercise more frequently than individuals who are a little bit older, so 18 and 19. So again, yes, we are talking about age, but there is a certain granularity in what we are talking about. Again, association between sudden death during exercise and underlying etiology. In this case, we investigated specifically patients who die suddenly with hypertrophic cardiomyopathy diagnosed at the postmortem examination. These were just young individuals, age 10 to 30. And you see that if we think about individuals who were age 10 to 15, most of them died during exercise. And this trend instead was reversed in individuals who were slightly older. Sex is another important variable. Previous studies have shown that there is a ratio of 10 to 1 in terms of the male to female ratio. So males tend to die suddenly more frequently than females. And this is also our experience at St. George's. You see 98 females versus 650 males. Also, the etiology of sudden death was very different. So predominant SADs in females, cardiomyopathy is more frequent, particularly arrhythmogenic cardiomyopathy more frequent in males. Why sudden death is more common in male athletes? This is a great answer. We don't have, this is a great question. We don't have any answer. There are various hypotheses. It's possible that there are some genetic variables, some hormonal variables, a possible maladaptation to intense exercise in males, and the possible presence of left ventricular fibrosis, which has been observed at cardiac MRI studies in males and not in female athletes. Sudden death in non-athletes appears to be more predominant also in male athletes. So this is a trend that is present not only in athletes, but also in non-athletes. You see, these are very important studies. Males seems to be more affected. What about ethnicity? I would like to mention this study that we recently published just a few months ago. And in this study, we looked on 848 athletes who died suddenly, who were referred to our center at St. George's. You see, again, predominance of sudden arrhythmia death syndrome, but there is a strong variability in terms of ethnicity. So, for example, Black athletes tend to die suddenly more frequently due to arrhythmogenic cardiomyopathy. Instead, Asian athletes, both South Asian and East Asian, had a higher prevalence of coronary artery disease, atherosclerotic coronary artery disease. And finally, I would like to mention findings of uncertain significance, because I think this is an important matter, which is certainly understudied. So, starting from this pie chart, the study that I previously mentioned, you see that in 16% of our athletes who die suddenly, we found idiopathic left ventricular hypertrophy and idiopathic fibrosis. And it's important to remember that we need to trust our cardiopathologist. I'm a cardiologist, so I work with a cardiopathologist. So we need to trust our cardiopathologist, because there is a very strong disparity in diagnosis. In this study, when we looked at local pathologists versus the diagnosis from Professor Mary Shepherd's group, the disparity was very high, 41%. This has massive implications for us as well, and for the family members, because if we don't have the correct diagnosis, then we don't know how to organize the family screening for family members and which test to ask. Going back to the findings of uncertain significance, I mentioned idiopathic LVH. What does it mean? Idiopathic LVH means that there is hypertrophy of the heart in someone who dies suddenly, but there are no features of hypertrophic cardiomyopathy. And particularly, I'm referring to myositis array, which is a pathological hallmark of the disease. So we asked ourselves whether idiopathic LVH and hypertrophic cardiomyopathy are perhaps the spectrum of the same disease. And to do that, we try to look at family members, first-degree family members of individuals who die suddenly showing idiopathic LVH at the post-mortem examination. We investigated more than 120 individuals with a quite comprehensive diagnostic workup, including ECG, echo, 24-hour Holter exercise test, and CMR. And these are the results. So we asked ourselves, is idiopathic LVH hypertrophic cardiomyopathy? Well, we could not find any case of hypertrophic cardiomyopathy in our first-degree family member, suggesting that idiopathic LVH is a different condition from hypertrophic cardiomyopathy. You see that channelopathies were more common in after comprehensive diagnostic evaluation. And finally, molecular autopsy. Molecular autopsy has been studied by different groups in the world, including our group, on a large cohort of more than 300 individuals who die suddenly. You see that 16% of individuals who die suddenly in this cohort showed a pathogenic mutation in channelopathy genes, but also in cardiomyopathy genes. So molecular autopsy, genetic testing the disease, has a promise to potentially guide family screening. And this is a recent study from our group again on molecular autopsy in athletes who die suddenly. You see 70% had actionable variants, both in arrhythmogenic cardiomyopathy cases, but also in SADS cases. And we found also cardiomyopathy genes in SADS cases. So I would like to conclude with a few take-home messages. The first is that I hope I convinced you that there is an extreme variability in the reported epidemiology of sudden death in athletes. There has been a paradigm shift in the etiology of sudden death in athletes. Hypertrophic cardiomyopathy is not the most common cause, according to recent studies. SADS, so normal heart at the post-mortem examination, is an important cause, or it's an important finding in individuals who die suddenly at a young age. Sudden cardiac death is more common in male athletes, and we don't know why. So there is a lot of research to be done in this field. Ethnicity counts. Arrhythmogenic cardiomyopathy is particularly common in Black young athletes. Coronary artery disease, atherosclerotic coronary artery disease, is common in Asian young athletes. And finally, we have to remember that when there is a sudden cardiac death, the process does not stop there. Family screening is incredibly important to identify family members at risk. Thank you very much for your attention.
Thank you very much, Gherardo. We decided to collect the question at the end of the session, but as far as you are far from us, I think that if we have some questions for you before the next presentation, I think we can. No question. I have just very fast, but I think difficult question for you, Gherardo. A clinical question. You know that in most countries, pre-participating screening is not mandatory. Considering the cost-benefit ratio, do you think that which exams you consider necessary, and especially do you think that just an ECG can be enough for most athletes before starting competitions, or do you think that, as in many countries, should be given up to the athletes and to the local legislation? What is your opinion on this issue?
Thank you, Massimo. This is, as you said, it's a very controversial issue. So I can tell you what I think. So I think that the ECG is the most important test to identify individuals at risk. I tell you this because at the end of the day, the ECG is abnormal in most of conditions that may lead to sudden cardiac death in young individuals. Just the graph that I showed to you, if we're talking about less than 35 years old, at the end of the day, cardiomyopathies and channelopathies are the most common causes. And the ECG is abnormal in most of cardiomyopathies and in most of channelopathies. Now, if your question is, would the ECG identify all individuals that are at risk of dying suddenly? Clearly, the answer is no, but there is no screening test in the world or in any specialty of medicine that has a 100% accuracy. I think that there is debate about potentially adding other tests, such as, for example, the echocardiogram. I think it depends. There is a cost benefit. Clearly, employing the echocardiogram in every athlete that comes to our door is expensive. The echocardiogram would have the added benefit, if it's done well and properly, to identify anomalous coronary arteries, which is the another important cause of sudden cardiac death in young athletes. I think you alluded to leaving to the athlete the decision. Again, I think this is potentially an area that will need to be discussed in the future. I think that, generally speaking, at least in my experience, athletes do not refuse to receive cardiac screening, but they may react in different ways according to the results that are given to them. So, for example, an athlete who is found to have a cardiac condition, especially if he or she is a professional athlete, high competitive athlete, may have profound implications for their life, also for their financial matters, etc. So I think perhaps it is at a later stage in the process that we may have to rethink about shared decision making and engaging with the athletes without necessarily prohibiting and forbidding sport in the athlete, but try to explain and inform the athlete about the risk and at the same time respect the autonomy of the athlete and their choice.
Thank you very much. I totally agree with you. So, if there are no other questions, we can go on with next presentation.
Thank you a lot. Yes.
Sorry,
from Skopje, Macedonia. It's okay, don't worry. Okay, I have nothing to declare except the privilege to visit this beautiful town of Trieste. 30 days survival has been doubled last 2 decades because usually resuscitation strategies are better now. But nevertheless, only 10% survive after sudden cardiac arrest. And my task for today is to talk what to do and how to do it properly in these 10% of patients. So, sudden cardiac arrest survivor, how do they feel and how the doctors feel? This sudden shift from apparently healthy person to a person who has life-threatening disease is something that makes this person to feel vulnerable, to feel confused, to feel in pain, to be afraid of the future. How do I feel as cardiologist? I would like to implant ICD to everybody that survived cardiac arrest and to go to sleep, but it's not the proper way. So the other good way is to send blood for genetics and then to wait for genetician to give me proper diagnosis, and it's not possible, of course. So what are we doing in these cases? I will suggest one 5-step approach to this patient. First, initial diagnostic evaluation, then management of comorbidities and risk stratification, then long-term monitoring and rehabilitation. Of course, it's not fourth genetic testing and family screening, it's something together with this third part, and then at the end, family counseling and support. Of course, I will try to stick to all these guidelines, not to tell my opinion, but to combine everything that I read from guidelines and tell you what to do properly. Initial diagnostic evaluation, of course, it's personal history, the main part. There are studies that shows that trained person, not the doctor, not cardiologist, trained person could take better personal history than cardiologist. Maybe patient is more afraid from cardiologist and for questioning from cardiologist. So trained person who could go further to third degree of relatives and asking for conditions could do better job in this. And really we must give right place to history and emotional status of the time of sudden cardiac arrest. And afterwards, of course, like doctors, we should do physical examination, especially in syndromic features. We have heard about Naxos disease this morning. So really, we should open our eyes wide as doctors and examine the patient properly. First data we get, we know the age of the patient and we know the circumstances in which this sudden cardiac arrest happened. So we have an idea what should be the background of this sudden cardiac arrest. Of course, we take blood tests. I don't want to lose time here to talk about blood tests, but I just want to point that collecting the blood for subsequent DNA analysis should be also the first step, not to forget, because 24-hour survival is not the same like 30 days survival. So as we see the patient, first step is to collect blood for everything, for toxicological analysis, for DNA analysis. If we don't need this blood, then no problem, but if we have the blood, then we could be better doctors. 12-lead ECG is class 1. Of course, we need 12-lead ECG, but every ECG that could be taken from the resuscitation unit, from the implanted devices, from the monitor in the vehicle of medical help could be helpful. Of course, if 12-lead ECG is nothing special, then we could go for continuous heart rhythm monitoring and features like signal average ECG. ECG in sinus rhythm, 12-lead ECG, give us many signs of underlying diseases, as the previous speaker mentioned. In many situations, we could go straight to the answer analyzing this ECG. But we should be aware that maybe some repolarization and conduction changes could happen because of CPR, because of cardiac pulmonary resuscitation. So we should repeat the ECG, not be, how do you say that? Okay, repeat ECG every day during he's in the hospital, not to take one ECG and then believe in this first ECG. Imaging techniques, echocardiography, cardiac magnetic resonance, and coronary angiography, all of these examinations have class 1. Because we are going to, in 24 hours, we would like to reach the diagnosis. After all this, we could exclude myocardial infarction, we could exclude pulmonary thromboembolism, aortic dissection, hypertrophic cardiomyopathy, or dilated arrhythmogenic right ventricle. And this algorithm actually shows the same. So first step is to exclude STEMI, to exclude cardiac, to exclude ischemia, STEMI or non-STEMI or MINOCA. Then if we reach the diagnosis of ischemic heart disease, then we treat the patient. But if we exclude this, this diagnosis, we go further, and with echocardiography, we look for structural heart disease. The second step is, if in these two steps we exclude heart disease, then we should go and search for extra cardiac cause, because sometimes it's not the fault of the heart. Sometimes brain and chest CT scan could give us answer. So if we exclude extra cardiac cause, then we go and analyze blood samples and review repeated ECGs, and we go for functional tests. Because at this point, we think it's probably primary electrical disease. So nothing structural that could be seen, nothing on the ECG, and we would like to find if there is some primary electrical disease. What about tests? Class 1 is exercise stress test, and class 1 is sodium channel blocker challenge. If there is no structural heart disease, then after a few days, we are very happy to continue with stress test, because if something happened during physical effort, we want to reproduce it. We want to reproduce the conditions in which sudden cardiac arrest developed, or we could put the heart in the condition where somebody something which is covered could express. Exercise stress test could induce monomorphic VT from right ventricular wall, suggestive for arrhythmogenic right ventricular dysplasia. Exercise stress test could uncover epsilon waves, again showing arrhythmogenic right ventricular dysplasia. Exercise stress test could unmask Brugada syndrome, the disease of the potassium channels. Also, exercise stress test could induce bidirectional ventricular tachycardia, suggestive for catecholaminergic polymorphic VT. Now I would like to mention implantation of ICD, because in this patient, if the disease is CPVT, implantation of ICD is wrong. It's not the right decision, because adrenaline that races at the first shock could bring this patient to VT storm, and then we will lose the patient because of ICD, not because of the disease in the background. And there are some unanswered questions regarding this ECG test. How should the test be performed? Treadmill or bicycle? Standard protocol that we use in cardiology clinic, or other protocol? Because there are no data which kind of test should be done. There is one suggestion for CPVT, that burst exercise test is better to unmask CPVT than normal stress test that is going gradually up to the effort. when would it be performed? Either during the hospitalization, immediately after the hospitalization. Should it be repeated and when? I don't have answer for these questions. We could discuss later. One very simple provocative testing is, it has a class 2A indication, is unmasking the phenomenon of QT stunning, is recording ECG during standing, not lying. Because during lying, QT interval could be normal, and then during standing, it prolongs that, how we could unmask prolonged QT interval. Coronary spasm, we could test with ergonovin testing or acetylcholine testing if we suspect there is this kind of problem. And sodium channel blocker challenge for Brugada syndrome, or sometimes we could just put precordial leads a little bit upper, not in third intercostal space, but in second, and we could see this elevation in V1 to VT in Brugada patients. Accessory pathway, this test has 2B class, but if we give adenosine, then we block the AV conduction, and then we could unmask accessory pathway. We get to maximal pre-excitation. And sometimes young cardiologists are confused. They say, oh, this is very strange. This patient get left bundle branch block when it's slower heart rate, and it's not frequent dependent left bundle branch block, but it's not left bundle branch block, it's accessory pathway and maximal pre-excitation in slow frequency. There is no place for electrophysiology study except if we suspect pre-excited atrial fibrillation or bundle branch reentry. Why do we need diagnosis? We need diagnosis to focus the treatment, not go to the first slide, not to put an ICD and go away, but we need diagnosis to tailor the treatment, to relieve the symptoms and to prevent the progression of the disease. Because it's not just curing, ICD is not curing, ICD is preventing the sudden death. And if we are not aware of the disease and of the process of curing the disease or stopping the progression of the disease, we did nothing with ICD. Management of comorbidities and risk stratification, so it's easy. It's easy because we know how to treat the comorbidities. It's not easy because sometimes we are not aware that we are not doing proper work. Then we are focusing on the heart and we forget that this patient is obese or have diabetes or have renal disease. So it's very important, and we should be doctors, not just cardiologists. And treatment, of course, tailored treatment, and now we go for long-term monitoring and rehabilitation. Rehabilitation, it's the thing as cardiologists we are not doing well. Only 34% of the patients who survived cardiac arrest are going back to their normal life and work. It's a Danish study, of course. And now I want to show you an example. This is a Holter recording from a patient of mine. He's 32 years old, and he collapsed on his own wedding 2 times. And then he was admitted to the hospital and examined for 48 hours, and nothing was found. Everything was normal. And then they put him long-term Holter ECG and released him home. And during that day, as you see, it's not very good quality, but as you see, he started to have VT. And then in this first red arrow is from VT, he advanced to a systole, which is very strange. Usually we see after VT, we see ventricular fibrillation, not a systole. And then he was in a systole like 70 seconds. And then at the second arrow is escape rhythm, and he survived. He survived. And until today, he's on sick leave. So it's impossible to send him back to work. I know this patient when he was 17, so I know him many years. He collapsed in somewhere in United States. He was on athletic exchangement. He collapsed. It was diagnosed as syncope of unknown origin, but during effort. For cardiologists and for the doctors who work with athletes, syncope during effort is alarm. It's never for nothing. It's always some disease. So he collapsed and he got loop recorder because nothing, they discovered nothing. They did genetic testing in United States and he was not sharing this test with me. He said, it's my private thing, I don't want to share it. So he came for controls to me for 3 years with loop recorder. We didn't notice anything except some sinus pauses of 2.5 seconds, nothing special for a person who is physically active. No single extrasystole, nothing. After 3 years, we explanted the loop recorder. He was, for me, completely healthy because during all examinations, ECG, echo, we didn't have magnetic resonance imaging 15 years ago. He was healthy and he disappeared from my sight like for 10 years. And it appeared that his genetic testing was suggestive for arrhythmogenic right ventricular dysplasia, which was the main problem. He didn't share this because cardiologists from here know that physical effort is forbidden in this patient because physical effort make this disease to progress. So that's why it's very important to talk with this patient, and we implanted an ICD, of course. We did counseling and things, and I said, okay, you could go home, everything is okay. He's counting his ventricular extrasystole, and he's coming, like every week, he's coming to see if everything is okay, and this is one episode of VT terminated with ATP, which means no pain, nothing. He felt the episode, but it's no way that he could go back to normal life for now. So we don't know how to do rehabilitation in these survivors. Who should do that? Psychologist, cardiologist, trained person, nurse, family? I don't have answer for that. And I'm so happy that so many talks were before for genetic testing, because for me it's very difficult field, this of genetic testing. So I don't lose a lot of time in this. Why do we need it? We need it to confirm the diagnosis, to think about prognosis, to know more about the disease, and sometimes we should tailor the treatment in the concordance with the genetic testing. Why do we need? Because we really, from autopsy, as we have heard before, we find normal hearts in many victims of sudden death. And idiopathic VF is diagnosis which says we don't know what is the diagnosis. It's not that diagnosis doesn't exist. As we admit as a doctors, we don't know the reason why this person have had sudden cardiac arrest. Because this study shows that if we follow up the patient for many years, then we find out the diagnosis, maybe in most of the patients. So how should be done, the genetic testing? I'll show you example of one disease, which is typical phenotype and genotype connection. We see the patient with long QT syndrome. Then we cure the patient, we give beta blockers, we implant ICD if there is indication, or we proceed with left cardiac sympathetic denervation. And all first-degree family members should have an electrocardiogram. All should be screened if their ECG shows long QT. Then we will have clear cases, yes or no, and we have borderline cases. And then in these patients, we continue, in these families, we continue with cascade screening in family members, because we want to protect them and protect the offspring of these families. I'm just, at the end, I want to tell when not to perform genetic testing. Not to perform if in index patient, there is insufficient evidence of a genetic disease. Then we don't send blood for genetic testing of every family member because it's expensive and because we could get results that are confusing, and then because we don't know what to say to this family if we get something which could not lead us to conclusion. So family counseling and support, who? First degree relatives, relatives with suspected symptoms, relatives with genetic burden. If genetic testing in the person who gets sudden cardiac arrest detect a pathogenic mutation. What to do in family members? First, medical history, physical examination, standard and high precordial ECG, echocardiography, exercise testing. So do everything before genetic testing, not to start with genetic testing. When? So after the situation, and children should be scanned until they reach adulthood, because sometimes during years things change. And when not, do family counseling and support if there is no clear-cut diagnosis in the sudden cardiac arrest patient and no symptoms in members of the family. What I would like to tell the family, if we do not implant an ICD, I would like to educating them on emergency settings, what to do, who to call, and how to start reanimation at home. I would like to thank you for your attention. You could scan this, and it's invitation for our Rhythm MUC International Symposium. The first one was in 1998. And now after 26 years, the second one will come. Thank you.
Thank you very much. So now we can move on to Matteo Dal Ferro now. It's correct, I hope. Who will speak with major ventricular arrhythmias in cardiomyopathy.
Thank you again, and sorry again I apologize. So, thank you all for your effort in being awake after lunch. So it's really difficult, I know that, and I'll try to keep you awake also during my talk. My outline is, what we can learn from survivors, in other words. So, major ventricular arrhythmia and cardiomyopathies, I will briefly show crude incidence and then detailed scores of major ventricular arrhythmia in cardiomyopathy in order to identify maybe some common predictor of sudden death in the young. This is my talk, my outline. At the end, I will briefly mention generalized and complex diseases, early markers of cardiomyopathy, and then possible preventive strategies. So, this is the crude incidence, overall incidence of sudden death events in the different cardiomyopathy phenotype, dilated cardiomyopathy. There is the arrow here. Okay, thank you. Hypertrophic cardiomyopathy and arrhythmogenic cardiomyopathy. This is a review from a couple of years ago, 1 year ago. And you see the incidence is quite, let's say, significantly higher than general population, but still the number means, on the other hand, that the vast majority of patients does not suffer the risk of sudden cardiac death. There is a sort of scaling of incidence in which arrhythmogenic cardiomyopathy by itself present the higher incidence of cardiovascular sudden cardiac death, followed by hypertrophic cardiomyopathy, and then dilated cardiomyopathy with 0.15% per year of sudden death events. So, but we have to keep in mind that those incidents are really non-specific, they are crude, and they does not go into the details of the different phenotypes that characterize each one of these difficult terms that, my presentation followed the excellent presentation of my colleague about this deep phenotyping in cardiomyopathy. So, okay, these numbers are significantly higher than in general population, but we have to really avoid generalization and keep in mind that there are cardiomyopathy phenotype and gene-specific arrhythmic risk and predictive score. that somehow teaches us which are the main risk factor for arrhythmias in this population. So risk score by itself generally use data from different clinical feature, phenotypic feature, genetic feature, and so the sum of this factor allows you to calculate an individual score to reach a risk stratification and then a categorization of patients into low risk, medium risk, and high risk. So we focusing on our specified outcome of interest. So you are supposed to individualize, to focalize, to stratify correctly your patient prior to the event of interest. So basically there are two kinds of scores. There are phenotype-based score and gene-based risk score. So unfortunately, gene-based risk score are available only if we are talking about Mendelian diseases. In the other hand, phenotype-based clinical risk factors are always available in our population. But in the next slides, I will show you in each score how many factors that drives arrhythmic risk depends upon phenotype or to genetics. So we can calculate at the end, trying to summarize which is the most prevalent and important predictive factor for arrhythmia. So I will use this slide as a framework, and so we will integrate phenotypic-based risk assessment and genotype-based risk assessment in the different cardiomyopathy phenotype. We will start from hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy could be considered a different disease, a distinct disease, different from dilated phenotype, I mean non-hypertrophic phenotype. We can just merge these two categories. And if you focalize on the arrow, you can appreciate that hypertrophic cardiomyopathy is not connected to genotype-based risk assessment. This is quite interesting since today we have no evidence that in cardiomyopathy the genetic status drives the arrhythmic risk. There is actually no evidence. This is really different when we're talking about non-hypertrophic cardiomyopathy. I think every one of you knows this score, which is a clinical-based sudden cardiac death risk calculator. It is broadly used from all clinicians which are involved in following patients with hypertrophic cardiomyopathy. You can appreciate that most of the variables are phenotypical variable and clinical variable. So, and most of them probably does not allow patient to be symptomatic for them, apart from probably LVOT gradient. And as you can appreciate, this risk score allows you to stratify patient with really higher risk in respect to the broad risk that we show at the beginning of this presentation. So there are patients with multiple risk factors and risk of event higher of 6% per year. So are really useful from a clinical point of view, this clinical score, and allows you to, let's say, trace backward the footprint of arrhythmic cardiomyopathy, arrhythmic hypertrophic cardiomyopathy. So in the flow chart for ICD implantation and primary prevention, there are only clinical variables, no genetic variable are considered in this case. And if you find yourself in, I don't know, I'm not able to find the arrow, but in the, let's say, low left chart for low risk patient, you can still use, you can still use another kind of phenotypic markers of arrhythmic risk, and two of them, apical aneurysm and fibrosis, late gadolinium enhancement, are usually asymptomatic. We should keep in mind that this risk score is not for all. I mean, could not apply to pediatric patients or to cardiomyopathy phenocopits, let's say, or to athletes, and obviously in secondary prevention. This is just to underline the guidelines for hypertrophic cardiomyopathy, in which it is clearly stated the usefulness of genetic testing, the assessment of risk of sudden cardiac death is uncertain in hypertrophic cardiomyopathy. In the other side of the framework, the there is a complete different interaction between phenotype and genotype. So let's start about arrhythmogenic right ventricular cardiomyopathy, in which we can, actually we have available at least one risk calculator. And as you can appreciate, the arrow connect the phenotypic assessment to the genetic assessment, and we'll see later. And here you can appreciate which are the clinical variables that confers you an higher risk for arrhythmic major ventricular arrhythmia in arrhythmogenic right ventricular cardiomyopathy. Most of them does not involve an assessment, a phenotypic assessment of the heart apart from right ventricular ejection fraction. But the highest weight for the score came from easily available clinical variable, let's say, so clinical history and EKG and HEG Holter. And as for hypertrophic cardiomyopathy, the different combination of these risk factors allow you to stratify your risk, and the arrhythmic risk may be really higher in respect to the broad category risk. This risk, if integrated with the genotype, allows you to clearly identify some genotype drives performance. The performance of this score works good if you're talking about RVC with plakophilin variant. In other words, the performance of this score is really lower for gene-elusive patient or for patient with desmoplakin variant presenting with arrhythmogenic right ventricular cardiomyopathy, and this is to be keeping in mind when you assess your patient. And so you need the genotype to fully stratify with more accuracy the risk of a major ventricular arrhythmia also in RVC. And finally, the most complex phenotype and the most overlapping phenotype, which is DCM, non-dilated left ventricular cardiomyopathy, which is still debated as a category of phenotypes. And as you can appreciate, this initial phenotype-based risk assessment soon drives you to the genotype-based risk assessment. And as you can see, we have several different risk tool depending on the underlying genotype. And here there is another one which is being developed now from our center about filamin C phenotype. This integration is quite consistent among different studies. Our group and other groups demonstrate how usually a genotype-based classification of your patients allows you a more precise and accurate risk stratification, especially for arrhythmic risk. You can, I mean, in this study, we just classify patients between arrhythmogenic genes carriers with desmoplakin, plakophilin, filamin C, and lamin against, let's say, less arrhythmogenic genotype, so such titin and sarcomeric variant. So we need to start changing our approach, starting not from the phenotype, because usually, as you all know, dilated cardiomyopathy can be considered the final common phenotype of several different pathogenetic mechanisms. So maybe it could be useful to start from the gene when it's available. If you're talking about Mendelian cardiomyopathy, so we are still looking at 1/3, half of our cases. But if you have the possibility to find a genotype which is Mendelian, you can start thinking, starting from the genotype and then declining to the different phenotype that are associated with this genetic background. So I will briefly show you the most frequent risk score, gene-based risk score on dilated cardiomyopathy and non-dilated cardiomyopathy. This is the first one. Lamin genotype, you all know that it is the genotype which is associated to the worst prognosis from combined outcome, both heart failure and arrhythmia. There are multiple studies that, about the penetrance of this variant, and depending on also on the class of gene variant, truncating versus non-truncating, that it is for the first time this factor is included in the risk assessment of the. So it's really pivotal, the genetic in the management of these patients. So this study just show you a sort of waveform of symptoms. So probably in Lamin cardiomyopathy, the first manifestation of disease usually involves supraventricular arrhythmia, and then are followed by ventricular arrhythmia. It is somehow contemporary to the involvement in terms of left ventricular dysfunction of the left ventricle. So also this is important that you can expect that you cannot exclude a Lamin patient if you face a young patient with a supraventricular arrhythmia or atrioventricular block especially. So these are the factors that are included in the Lamina C risk score. As you may appreciate, even in this case, only one of these factors depends on the echocardiographic assessment of left ventricular function. The other contains mostly clinical variable, the genetic class of Lamin variant, and the arrhythmia, supraventricular arrhythmia, that can be easily detected by EKG, to answer to Massimo's question before, and Holter monitoring. As for other comparison in respect to the broad class, this is the incidence rate, as you remember, of the broad class of dilated cardiomyopathy, and you may appreciate that patient with the highest score faces a 50% risk of sudden or major ventricular arrhythmia in 5 years. So quite different. There are another recently developed risk score which has not been validated, and this is not only gene specific, but it is mutation specific on this single founder effect variant which involves the phospholamban gene, really common in Dutch in Holland, but here is quite rare in Italy. I don't know in the other countries, but we really rarely found it. Then, really recently, there is the new score for desmoplakin variant. So you can we are shifting to the paradigm, starting always from gene and then going to phenotype. And as for the other score, we can appreciate that factors that rely on the performance, on the function of the ventricle, are on the top of on the bottom of the score, let's say, and multiple of these elements can be detected only by clinical history and HG and HG Holter. And the comparison is always quite different in respect to the crude incidence. This is the last that our colleague Marta Gigli and others from our center is developing in an international efforts, which is not still being validated. The paper is still under submission, but these are the factors that seems to be strongly correlated to increased arrhythmic risk if your genotype is filamin C truncating variant. And per comparison, always, even if you are in the lowest classes of risk, your risk is higher in respect to the broad category of dilated or non-dilated cardiomyopathy patients. And if you have an intermediate risk scenario, your risk of 2 years is really higher, 25% of risk of events. And for the higher risk scenario, the risk of events at 2 years is almost 1 case out of 2. So the importance of gene drive risk assessment. In other words, there is, in effect, this meta-analysis really recently published support our finding, because if you stratify the risk for major ventricular arrhythmia depending on the morphological assessment of left ventricular dysfunction, you basically have no association with arrhythmic risk. This is quite new as a concept, but it is increasing. It is consistent among different cohorts of patients with genetic cardiomyopathy. From the other hand, if ventricular ejection fraction is not predictive, the fibrosis is predictive regardless of the ejection fraction. So fibrosis seems really a common clinical risk factor for major ventricular arrhythmia among non-ischemic dilated cardiomyopathy patients. So a brief mention to, we were talking about gene driver risk score, but we have to keep in mind that the vast majority of patients with cardiomyopathy has no genotype, Mendelian genotype underlying. So we should remember and consider probably sudden death, as my colleague have showed previous to me, that it is a a complex disease, and so the genetic dark side of cardiomyopathy needs further research during the next year to be properly investigated. There is probably a multifactorial genetic predisposition and an environmental interaction. But this, you see, this gray pie chart is the one that we assess also in when we do genetic testing to cardiomyopathy patients. So the vast majority is always non-Mendelian. And this is probably, it is worth focusing on this cardiomyopathy as complex diseases, and we need further research on this aspect maybe. This data is just confirmed. My colleagues already show multiple studies with similar results, but just to, this is quite exemplificative since starting from 304 families of victims of sudden death, just almost a half of probants of victims received cardiomyopathy diagnosis, but among the relative screening, only the 10% show sign of diseases. And in line with complex heritability, non-Mendelian heritability. But on the other hand, we should underline that even if the proportion of screener relative in which we found a disease was considerably about 10%, 12%, still it allows us to perform some life-changing disease-changing interventions such as ICD implantation, which currently interrupt about 6 abortus at the cardiac death or sustained EVT. So the importance of family screening. I think that family screening is really important, not only for, I don't want to overlap with other presentation, but another important thing that we can learn from relatives, we can learn the early marker of cardiomyopathy. Usually relatives are faces family screening in early age, so we can appreciate the disease at the beginning you are supposed to. And it is interesting to focalize on what are the pathological exam on relatives that show no sign of left ventricular dysfunction at baseline. This is a study from our end. You can appreciate that the Holter monitoring and the HCG the Holter especially is pathological in about 1/5 of relatives with no other sign of diseases. And this is in line with a recent review from circulation research and from a study in JAMA, which show you the highest prevalence of DCM causing genetic variant for early onset atrial fibrillation. So if about 10% of patients with in the broad category of ages with atrial fibrillation isolated were carrier of a pathogenic variant, and if you go below the age of 30, the percentage of the diagnostic yield raises to almost 20%. And for genes involves not only in dilated cardiomyopathy but also in channelopathy and arrhythmogenic cardiomyopathy. So the importance of identify the supraventricular arrhythmia from other studies in relatives consistently show that the family screening by itself modifies the prognosis of relatives. We still don't know exactly why, but probably because you can at least apply some lifestyle changes or maybe to treat some risk factors such as hypertension or obesity in the young relatives, so still showing disease sign, but also in our cohort, the most important thing is that the arrhythmic risk of relatives is modified by the family screening, so by the early detection of the disease. Together with this, it's important to underline the strong association of abnormalities of HCG Holter at baseline with the risk of major ventricular arrhythmia. So to conclude, this is the last, which are the common feature of major ventricular arrhythmia and sudden death across all the cardiomyopathy spectrum. So probably the first angle and the first point is the most correct, even if provocative, but still we can recognize some pattern like young age, the absence of heart failure symptom, the subtle fibrosis, which does not impair ventricular ejection fraction at that stage, a possible family history of cardiomyopathy, and a possible history of supraventricular arrhythmia. Rare predictors include syncope and palpitation, and in line with the question from Dr. Zecchin, the more accessible and probably effective screening technique may be just EKG and 24-hour EKG Holter monitoring. Thank you.
Thank you, Matteo. So, move on to next presenter, Dr. Slobodan Klašnja. I hope I pronounced quite correctly. From Serbia, who will speak about cardiomagnetic resonance as a powerful diagnostic tool in mosaic of sudden cardiac death diagnostic. Is it possible? Please.
Yes, you pronounced it better than most Serbians. So, I'm Slobodan Klašnja. I'm from Belgrade, coming from a University Hospital Center Bežanijska Kosa. I bring my best regards from Professor Zdravković, that is she couldn't make it to this meeting, and we'll talk about cardiomagnetic resonance as a predicting and powerful diagnostic tool of sudden cardiac death. Sudden cardiac death, as we all know, is the fifth most common cause of death in the world. Aside from advantages that's brought by ICD in primary prevention, only 3/5 of the patients have ejection fraction lower than 35%, while only 2/3 of the patients have ICD have appropriate shock therapy. Risk stratification in patients with ejection fraction higher than 35% and structural heart disease is still a clinical problem. So basically, about 40% of patients that suffer sudden cardiac death has ejection fraction higher than 35%. CMR or cardiomagnetic resonance offers us a broad spectrum of techniques that we can use to characterize tissue of myocardium and differentiate between inflammation, edema, and fibrosis, thus enabling us to recognize specific patterns and helping us in differential diagnosis and prognosis for every patient. And the therapy can be also monitored through follow-up cardiomagnetic resonances. Risk stratification for sudden cardiac death is basically all about myocardial fibrosis. And we can see here that before the era of cardiomagnetic resonance, we all were taught that left ventricular ejection fraction over 35% carries a low risk of sudden death or sudden cardiac death. And since the introduction of cardiomagnetic resonance, we see that myocardial fibrosis represents significant risk factor on its own. So if the patient has a left ventricular ejection fraction of 35 and greater and has myocardial fibrosis, it carries a medium to high risk of sudden cardiac death. LGE is a predictor of sudden cardiac death. We can see that on this forest plot. And what is the LGE? LGE is late gadolinium enhancement, meaning that gadolinium that is contrast used in cardiomagnetic resonance is usually bound in the extracellular space of myocardium, not in cells. So we can see that ventricular arrhythmia and sudden cardiac death with bigger gadolinium, bigger LG is a significant predictor of sudden cardiac death. Also, we can see that in this risk stratification, we need to have in mind where the gadolinium is deposited, and also how much of it is deposited. So if the LGE is 13% or more of left ventricular mass, we consider this patient to be in high risk of sudden cardiac death and ICD shock. On this slide, we can see that the gadolinium deposits show us show us what's the pathological substrate for this, and we see that transmural LGE is consistent with ischemic pathology, also as subendocardial LGE also ischemic, and the global subendocardial would show us amyloidosis, epicardial myocarditis, and so on. In stratification, risk stratification for patients that suffered myocardial infarction, we see that all these maps gives us a clue of risk involved, of risk of sudden cardiac death, and we see that post-contrast T1 map shows us extracellular volume that is over 31% is very consistent with left ventricular remodeling, heart failure, and death. Also, we can see on other sequences here that we can differentiate between patients that have bigger infarct size, intramyocardial hemorrhage. We can see T2 start map that shows us that is the one in the middle, that shows us intramyocardial hemorrhage associated with larger infarct size and lower ejection fraction, and poorer prognosis for these patients. On this slide, we can see LGE core and gray zone. This is the zone marked with the red arrow on the left. This is the zone of hibernated myocardium and myocardium at risk, and this can be saved if proper treatment is applied. Also, this zone is very much it's a zone consistent with ventricular arrhythmias. So we need to do our best to make our therapy protocol adequate. Myocarditis is one of the most prominent pathological states that we can see leading to a sudden cardiac death, and also on the left here we can see that gadolinium is stored subepicardially, and we in our hospital have the Lake Lewis criteria for myocarditis for the diagnosis. Myocarditis with LGE present has a significantly lower prognosis and higher risk of sudden cardiac death, and we see that it's almost double if compared to the patient that has no LGE. Also, with the patients that have left ventricular ejection fraction over 40% and has LGE present, we see that also these patients have poorer prognosis, higher risk for sudden cardiac death, and the patients that have less than 40% ejection fraction and LGE present have the highest risk of MACE and of death. So, talking about myocarditis, also patients, we need to differentiate where the gadolinium is deposited, and anteroseptal pattern that we see on the left, I think, we have no pointer. Anteroseptal pattern shows the lowest, the poorest prognosis and the highest chance of cardiac events in these patients. Follow-up in these patients is crucial, so we usually do a follow-up in 6 months, so as to see that if there is a change to LGE amount, and if there is an edema. If edema is present, then the myocarditis is not over, it's still has some time to progress, and we see that patients that have much elevated LGE compared to the first examination had a very big chance of sudden cardiac death. So this is on the right. So you see how much survival probability is lower in the patients that have LGE increased. Hypertrophy is one of the causes of sudden cardiac death in athletes. I said here that is most common, but I learned in previous lectures that it's probably not the most common cause of sudden cardiac death in athletes. But nevertheless, it represents a broad spectrum, especially in athletes, from adaptation to decompensation. And you need to have a more close look to the patients. And that close look is really about cardiomagnetic resonance, and it offers us more clear diagnosis. And we see that echocardiographic suspicion in almost half of the patients with left ventricular hypertrophy was changed after cardiomagnetic resonance. In all the phenotypes, we can use T1, T2, and extracellular volume mapping to see what phenotype is at hand, and make a differential diagnosis between Fabry disease, amyloidosis, cardiomyopathy, and so on. Importance of extracellular volume in patients with left ventricular hypertrophy in athletes can be crucial, because athletes are pretty much resistant to medical advice, especially if that advice forbids them to participate in sports. And we see that extracellular volume in athletes is lower, and in hypertrophic cardiomyopathy is higher because of the cellular disarray and extracellular matrix expansion. So we need to differentiate between normal conditioning of the heart and hypertrophic cardiomyopathy. Here we can see that risk stratification includes a broad amount of parameters that we can get from cardiomagnetic resonance, left ventricular mass, wall thickness, ejection fraction, LGE mass, LGE percent, and aneurysm presence. And we can see that all of these parameters can lead to more ICD implantations, progression to end-stage hypertrophic cardiomyopathy, and more admissions because of the heart failure. And we can always use the calculator that we use in our hospital, that we punch in a lot of parameters, and that gives us 5 years percent of sudden cardiac death. That is very useful in prognosis. LG is an important predictor of sudden cardiac death in both non-obstructive and obstructive groups, in both patients with or without myectomy. So this is very important. So all groups can be beneficial with the cardiomagnetic resonance examination. Risk stratifications with dilated cardiomyopathy. We know that patients with dilated cardiomyopathy and the low ejection fraction have poorer prognosis, but nowadays we use also the LGE in cardiomagnetic resonance to refine that risk stratification. So we see that if the LGE is present and the left ventricular ejection fraction is lower than 35%, annual event rate is 7.2. That is not that is not a small number. Intermediate risk also 2.4, also not small number. In patients that with the dilated cardiomyopathy, even better predictor of sudden cardiac death than the LG might be extracellular volume and native T1 time. And as shown here, it's another of cardiomagnetic resonance benefits in sudden death cardiac, in sudden cardiac death stratification. So basically, to conclude, sudden cardiac death is a huge problem, especially when you talk about younger people, and cardiomagnetic resonance is not only a part of the puzzle. I would say it's a factor that narrows down the filter in differential diagnosis and prognosis of sudden cardiac death. Thank you.
Thank you very much. So we move on to the last presentation. Prof.ssa Aleksandra Stanković, again from Serbia. Developing trustworthy artificial intelligence-driven tools to predict vascular disease risk and progression. Please.
Thank you. Thank you, organizer, for inviting me today. And after all of this we heard today, I think it's need to think about developing trustworthy artificial intelligence to predict cardiovascular disease risk and progression. I'm from Vinča Institute of Nuclear Sciences, National Institute of the Republic of Serbia, University of Belgrade, and I'm working in the Department for Health and Environment Research Laboratory for Molecular Genetics. First of all, we can ask if this concept of artificial intelligence is possible. Yes, this is possible now. For some certain areas, this is, of course, cancer, and artificial intelligence has been used to extract genetic profiling data for personalized chemotherapy used based on personal cancer mutation in patients. Also, artificial intelligence has been used to extract information from radiological reports and pathology reports to extract lung cancer staging from pathology results and breast cancer diagnosis. Artificial intelligence could be fed by data from the past, so can determine which algorithm provide the best indicator of the future trends. Also, artificial intelligent learning makes it possible to build diagnostic and therapeutic programs adapted to a specific individual, taking into account clinical, biological, and genetic characteristics of patient. But implementation of artificial intelligence is not happening as quickly as we expected, because in Europe there is a lot of economical issues, and also there is need for a paradigm shift for this. It has taking the time, and public authorities has consider the protection of patient data within European Union General Data Protection Regulation. And also there is a wide applicability of artificial intelligence and big data, which requires sophisticated regulatory oversights. And also there is need for introduction of new professions in clinical environment. So the interaction of medical practitioner and engineering is key point to avoid irrelevant clinical big data being analyzed and thereby giving irrelevant results. So we can say that for artificial intelligence, using of big data needs also people. There is a lot of engineering, data scientists, clinicians, and individuals, and also patients, because patients need to have a feedback in some studies. So current clinicians need to make decisions based on a lot of data. So if we apply artificial intelligence, we applied also machine learning and deep learning. And our goal is to do some study which include a lot of parameters. This is clinical, imaging parameters, digital health parameters, transcriptomics, genomics, proteomics, to prepare a clean platform to apply correct algorithm to analyze this data for personalized diagnostics, prevention, and treatment. There is a lot of machine learning algorithms. There is 4 types here. Presented: deep neural networking, support vector machine, k-nearest neighbors, and random forest. So I will do some short introduction in machine learning. Artificial intelligence is the ability of machine to make anonymous decision based on data collection with self-learning ability in repetitive data processing and adaptation to new data evolving over the time. In machine learning, a model learns from examples rather than being programmed with rules. And numerous algorithms can be used, and machine learning is generally classified into main categories: unsupervised and supervised. So we can make some difference between human learning and machine learning. Machines can learn from many examples. Humans can learn from small amount of data and make general association. So machine learns from a lot of data, and learn from these more examples can allow to uncover pattern which is not visible to the people and without the need of explicit instruction or prior assumptions. So machines have potential to automate human tasks and even to perform tasks beyond human capabilities. So we heard a lot of cardiovascular diseases today, including sudden cardiac death, and there is a lot of different phenotypes which need to be prepared for artificial intelligence analysis. Also, there is a lot of risk factors for cardiovascular diseases. You know that we're talking about that today. And beside this well-known lipids, gender, body mass index, smoking, hyperlipidemia, blood glucose level, and many marker genes, which are also important in this analysis, there is a lot of more markers. So this is extremely important to consider this lot of data. And until now, artificial intelligence was applied in cardiovascular diseases field for 1 or 2 sources type of data. For example, for imaging and clinical data, in combination of genetic and clinical data, genetic and lifestyle data, and imaging and genetic data. So in the future, we need integration of multi-source data into trustworthy artificial intelligence algorithm. There is one example of one type of signal. This is input of raw signal, which need to be converted from analog to digital and be prepared for analysis as numerical value, where numerical value is presented amplitude and the signal of the specific time. And it is going to convolutional layers and pooling to the convolutional neural network. There is an example of application of artificial intelligence, which can help us to recognize clinically meaningful QTc prolongation on the mobile ACG device. And this algorithm, in this case, this is deep neural networking algorithm, using 1.6 million 12-lead ACG from 500,000 patients for the deep neural networking application machine learning. And they used for training of this algorithm 250,000 patients, and for testing 107,000 patients, and for validation 179 patients. So there is a lot of patients and a lot of data need for prepare to have a gold standard. But they, in this work, they applied artificial intelligence successfully on a mobile device, and this device could monitor QT prolongation and could prevent sudden cardiac death. There is an example of application of artificial intelligence in acute coronary syndrome. There is two types of signals. This is data from patients and data from serum and urine. And they did a lot of analysis of different metabolic substances in urine and serum. And they applied multinomial lasso method and random forest artificial intelligence method, and then provide 4 metabolites, which could be some markers for differential unstable angina and acute myocardial infarction. But problem in a lot of work in this field, which can see here, this is only 300 serum and urine samples, which is different to the previous work, which is did on a lot of patients. So for artificial intelligence, we need to train and to do a lot of work to be done properly. So the other example is forensic identification of sudden cardiac death and approach which combine 2 types of data, metabolomics data from cardiac blood and cardiac muscle in postmortem samples. And they prepare machine learning model for certification of non-sudden cardiac death actual and actual sudden cardiac death. But also in this work, there is a problem with sample size and if this algorithm is trustworthy. So if we learn from some systematic review, there is a lot of different studies which are analyzed in this work, and there is studies range from 122 patients to 124,000 patients, and there is a lot of data analyzed, demographic, clinical, electrocardiogram, imaging, genetic data ranging from 4 to 72 variables per model, but only 11 studies meets inclusion criteria. So the workers concluded that there is a risk of bias, and there is a machine learning prepared applied in these studies is underapplied and incorrectly implemented, but it's ready for future investigation. So there is need for future better algorithm, trustworthy algorithm. If we talk about vascular diseases, prediction algorithm used for prediction of progression of disease and association with complication, prediction of survival and hospitalization, and prediction of complication related to treatment. So to develop this trustworthy artificial intelligence-driven tool, we are included in an ongoing project, which coordinator is University Medical Center Amsterdam. There is 14 participant organizations and 9 countries. And we have aimed to include a lot of data, a lot of medical data from patients, which is genomics, proteomics, electronic health records, and medical imaging, and also lifestyle data from patients, physical activity, heart rate and blood pressure, lifestyle, such as smoking, and quality of life. Also, we included feedback loop from the patients to prepare personalized cardiovascular and disease progression risk predictive artificial intelligence tool, and to have automated image analysis tool, risk prediction clinical tool, patient communication tool, and lifestyle application for personalized prevention strategy to do personalized medicine to stratify high and low risk patients. This project goes in line with the European Commission aims. They cover technical robustness, accuracy, reliability, reproducibility. Also, this tool needs to be effectiveness and also need to be validated. So we have 5,000 patient data from the retrospective study and 1,000 patient data for the prospective study, and we will do relevant, I hope, for end user tool in real world settings. So I hope that this will be fast and easy in the future, this trustworthy artificial intelligence tool, and for personalized and precision medicine need to be ethics, evidence, and equity. Thank you.
Thank you. Thank you very much. Very interesting task the artificial intelligence will be the future, and hopefully not a nightmare for most of us, because we are all afraid of consequences and not only of the opportunities. If there are any questions for all the presentations, we are a little bit late. If not, I will again thank Stefano.
Okay. We concluded the third session, and with Professor Aleksova and Dr. Linchinska, we decided to go to conclude instead of a discussion. So something. Sudden cardiac death is defined as a major challenge for public health, and social and economic costs are obvious, and I think all of us have to do much more to investigate this phenomenon, this strange phenomenon, because today we confirm that not ever we can answer to the question of the families. So we have a dream, but I think we have a great opportunity to think about a common registry. In my idea, and the idea is of a Balkan registry, where all of us can put their knowledge. But the road to an international registry is long, of course, and is difficult. Trieste represents the first step, but we are to work hard. The car of the Balkan registry is now on, and we have good pilots. Today, all the speakers are the pilots of this car, and we have who give the right direction, the leader in pathologists, in cardiologists, in radiologists and genetics. And of course, we can use the experience existent. Chara exposed what they do in Greece, and I think it is an excellent work. So, what to do now? I think that we have to start to share experience, to share our knowledge, to share our methodology, and to share our cases, to share common and uncommon findings, and to ask for a help when we need. And to discuss about something we really doesn't know completely. The problem of a variant of unknown significance is still on the table. Where we can do all of this? We can start here. Professor Georgi Alempievich accepted the proposal of the editor-in-chief of this journal. The Egyptian Journal of Forensic Sciences know about our meeting and contact Professor Alempievich and ask to Professor Alempievich, who shared with me and with my magister, Professor Vittorio Fineschi, to guest a special issue dedicated to sudden cardiac death. Obviously, he is improving his journal, but I think it is a first opportunity. My first thoughts goes to the young researcher who presented poster today. Why not? It's a great opportunity because it's free of charge. So, why not? And where to do more? Maybe here. Professor Jakowski proposed the second edition, and Skopje, it might be the place. It's the place where discuss our progress in this year. But 1 year is not necessarily long, so we have to work because a year passes so fast. So save the date. The appointment is last year in September in Skopje. And so I have to do just one thing. Final thanks. I wrote because I don't want to forget anyone and anything. Thanks to the Italian Society of Cardiology, the Italian Society of Human Genetics, the Italian Societies of Forensic and Legal Medicine, the Macedonian Society of Cardiology, the Macedonian Society of Forensic Medicine, the Serbian Society of Molecular Biology, the Serbian Society of Genetics, the Serbian Society of Forensic Medicine, the Balkan Academy of Forensic Sciences, the International Academy of Legal Medicine, the International Academy of Forensic Sciences, and the Ministry of Health of Ukraine. Thank you, Anzela, thank you, Vitaly, for coming here. I'm really happy to host you in these days. And the Italian Ministry of Foreign Affairs and International Cooperation for the partnership. Thanks to the Society of Cardiology of Bosnia and Herzegovina. Thanks to the Société Royale de Médecine Légale de Belgique, and to the International Society of Forensic Genetics for promoting the event by the social media. Thanks to Davide, Monica, Maria, and to be part of organizing committee, and to all the residents of the Institute of Forensic Medicine of Trieste. Thanks to Aneta, thanks to Georgia, thanks to Massimo for your support and to be part of the scientific committee. Thanks to Anna Maria for the support in these months. Thanks to Elio, Sara, and Valentina, my colleague. And thanks to, obviously, to all of you, all the speakers, all the attendants of the meeting. Thank you, Professor Shepard. And congratulations to the winner of the Best Poster Award. So we wait all of you next year in Skopje and enjoy your stay in Trieste. Thank you.